In 2009, Goldade wrote an article that reviewed reasons why undocumented Nicaraguan migrant women were denied state healthcare in Costa Rica. Despite having long-standing commitments to provide universal healthcare to all individuals on its soil, Costa Rica in 2004 passed a law that banned uninsured individuals from being able to access state-provided healthcare. This was due to a rising anti-immigrant sentiment. In 2002, according to Castro Valverde, migration to Nicaragua from Costa Rica has tripled in the past 20 years, and migrants made up 8% of the population. Since they were denied access to free public healthcare, uninsured people were required to pay a consultation fee of 11,500 colones. This was the equivalent of half a week's worth of wages in agricultural labor. As a result, this has affected economic, legal, gender, politics, and public health for Nicaraguan female immigrants in Costa Rica, producing exclusion among south-to-south migration circuits. Historically, in 1941, El Presidente Rafael Angel Calderón Gordia established the nationalized healthcare and the National Social Security System. In the 1970s, the state's emphasis on universalism or universal access to healthcare reiterated the state's importance in fulfilling health goals. Morgan, 1989, stated that by building up this reputation, the state was able to attract funding from international agencies. Also, Nicaraguans used to be classed as refugees due to civil strife and economic stagnation occurring in their homeland, but are now classed as labor migrants. This article has 3 key themes which I took out of it, which includes biosociality, medical citizenship, and biopolitic. In terms of methodology, Goldade used ethnographies and spent 13 months in Costa Rica to interview the effects of healthcare exclusion. The researcher lived in Florencia, a town that depended largely on the growing of sugarcane and coffee, thus relying on flexible and inexpensive Nicaraguan migrants. Goldade systematically reviewed 3 national Costa Rican newspapers, interviewing 12 healthcare providers, conducting 40 hours of focused observation between patients and nurse receptionists, and recruited and interviewed 43 migrant workers. So theme 1 is biosociality. According to Foucault, biosociality is when individuals illegally migrate to access and gain more economic or legal opportunities, but this has a trade-off in further harms to health. Ticktin in 2006 emphasized the importance of the biology of sickness and health being able to influence social structures, culture, and politics. Medical anthropologists stress the idea that migrants align with suffering bodies, who desire citizenship, entitlements, and legal rights. Goldade believes that medical anthropology helps to account for the health of migrants, and that intense globalized political economic hierarchy is to blame for biosociality and disparity that affects the migrants' access to healthcare. I think that this is a bit vague because you could technically blame every problem resulting from any disparities in social hierarchy. But that being said, this is similar to Foucault's 1976 idea on biopower, where peer pressure, self-surveillance, and self-discipline cause individuals to conform to norms that regulates health and sex. Biopower is employed through biosociality to decide which individuals are able to access healthcare. Biopower also manifests itself as negative portrayals of migrant workers, which includes notions that migrants were portrayed as morally inferior, sexually promiscuous, and excessively demanding on the system, undeserving of medical entitlements. These are forms of biopower since these views justify excluding healthcare resources to migrants and facilitates a state of constant surveillance from which denies access to the said services. The second theme that I want to highlight is medical citizen. Similar to biopower, medical citizenship is what Nichter 2008 defines as policies of entitlement that privileges the basic rights of citizens over the undocumented, dictating who gets access and who is restricted to health resources. Ong in 2003 stated that modernizing democratic states like Costa Rica requires citizens to take on civil duty to reduce their burden on society, and the Nicaraguan migrant woman is viewed as a parasite to the universal health system. Biopower serves as a way to enforce self-discipline of the state to safeguard precious so-called limited healthcare resources. By 2005, there was a public concern over the quality of healthcare, which was seen to be ever dwindling due to national media portrayals of the system as being overburdened, having limited funding, suffering from shortages of basic supplies, and competing with migrants. Medical citizenship, in essence, places biopower into practice by allowing for bottom-up control and surveillance, which was supported by the citizenry against the powerless and poor undocumented. Even though this appears to be a form of the classic divide of oppressor and oppressed relations espoused by Marx, one must consider also the agency present, which includes the choices the migrants and citizens themselves have made to come to work, interact, and depend on each other. It's not necessarily always purely rigid structuralism, nor is it always the effect of agency that neoliberalists propose, but rather the truth is somewhere in the middle, and being both bottom-up as of biopower and top-down as of the body politic. This leads me to the third theme, the body politic. What is the body politic? Scheper-Hughers and Locke 1987 defined the body politic as when suffering bodies are believed to be constrained by the larger globalized economy. Goldade met the social healthcare worker, Maria, during a time where there was debate and disagreement between the Ministry of Health and the Caja Costarricen's Seguridad Social Security. The Ministry of Health was responsible for public health campaigns and disease eradication. Salud para Todos, or Health for All, was the slogan of the Ministry of Health. The Caja, however, was concerned about the cost burden of treating a population. The Caja is kind of analogous to Centrelink here in Australia. Maria sided with the Caja, believing that healthcare was for those who could pay to use the direct services or through employment. In 2004, the law passed banning uninsured individuals from accessing public healthcare unless they paid the expense. Patients were required to show two documents, the state ID card and the pay stub, which indicates insurance status. These documents don't have photographs, which led to developing perceptions that Nicaraguans were using fraudulent documents to access health services, perhaps more than once. Just like Maria, many Costa Ricans feared that the migrants would exploit the health system excessively and deny citizens from access to these services. They also feared that foreigners wanted to explicitly migrate to exploit Costa Rican's healthcare system. This is similar to a Neo-Malthusian mindset, whereby the lack of supply and scarcity of resources may eventually be unable to meet demand, and thus drive citizens to advocate for withholding the limited healthcare resources from the undocumented. In reality, however, globalization or neoliberal economics on a global scale is more aligned with Wallerstein's 1974 world systems theory, whereby resources and people travel and trade, creating mutually beneficial networks of economic exchange. Thus, restricting universal healthcare hinders that flow somewhat. In conclusion, despite the Costa Rican state emphasizing healthcare for all, moralizing, fear of scarcity in access to healthcare resources, and social gendered structural and organizational ignorance of migrant needs, this has resulted in disparity in accessing Salud para Todos. The researcher believes that the real culprits were the employers, who evaded taxes and had lax labor conditions, which further exacerbated migrant health problems. In my own opinion, I think the citizens have a right to choose how their nation's resources are allocated, and are justified in biopower, biosociality, biopolitics, and medical citizenship to choose who gets healthcare however they wish. A fee is a price to pay for what citizens view as a means to privilege the citizenry. Without these divides, the difference between citizen and undocumented becomes blurred, and boundaries must be set not necessarily for the preservation of resources or morals, though these are some reasons, but rather to maintain the difference for its own sake, and perhaps encourage and incentivize the undocumented to become part of the citizenry. I admit that I don't know the barriers to become becoming a citizen of Costa Rica, or if that is even desired by the average migrant Nicaraguan worker. But I also do not know that giving access to health and social welfare to the undocumented in any country is a way to reduce inequality, when it is inequality in the first place that creates supply and drives the demand for cheap migrant labor. Thanks for watching. Bye bye.